Good morning, everyone, and welcome to the August 11th Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan. We don't really have any new guidance specific since our last webinar, but we have several updates, and we want to cover some of the issues that we keep getting questions about as usual. As we announced earlier, we have guests this morning from Plant Moran. They're going to help us better understand issues with provider relief fund reporting. Dalton, our Director for Public Policy, he'll start us off today with a brief update, and I will end with our normal situation update and discussion about guidance. So at this point, I'll turn the presentation over to Dalton.
Good morning, everyone, and I have the distinct pleasure of introducing a new staff member today. Her name is Crowley. She'll be joining us and kind of filling some unique roles and part of the roles of Blake as he's since moved to another position in Battle Creek. So with that, I'll ask Caitlin to give us a little bit about her background and what she's excited to be doing with the members today.
Yes, thank you, Dalton. Good morning, everyone. I'm Caitlin Crowley. I am the new education coordinator. It's actually my second day, so I'm very excited to be here. Just a little bit about me. So I actually do have a public health background. I recently obtained my Master of Public Health from Grand Valley State University with a health promotion emphasis. So health and education are just very important areas to me. I'm really excited to kind of hit the ground running, to learn all about, different resources and services, and really kind of dive into the logistics of, planning for the annual conference and things like that. So I'm very happy and excited to be here, and I'm looking forward to hearing the discussion today. Thank you. I'll just hand it over back to you, Dalton.
All right, thank you, Caitlin. So now we're going to move kind of into our normal advocacy update. It's going to be rather brief as the legislature is still kind of going to be out of session until after Labor Day. There are some discussions going on, but those aren't necessarily public conversations that are occurring, and most of them are regarding their own re-election campaigns and kind of gearing up. You'll typically see legislatures about 18 months before the next election cycle Lansing will kind of slow down as everyone prepares to shift into campaign mode and really start fundraising, and you'll see all the fun commercials on TV and yard signs everywhere as you would during a normal election cycle. So moving on to a couple of advocacy things. Over the last week, MDHHS and Laura have been looking to prioritize some of the recommendations that came out of the work groups regarding the survey process. Leading Age Michigan submitted our own priorities for the recommendations, and really, essentially, we wanted to tell the department, this is what you should be focusing on to really kind of help providers create a better state of long-term care and really help us care for the residents. I did copy the letter here, where you can see a bulleted list of our priorities. I did want to highlight a couple though, as I think they're important and really get to the heart of what the work groups were working on and kind of what we were trying to see change. Our suggested recommendations focused a lot about surveyor reliability and consistency. And sorry, the phone's ringing, distracted me. We also want to see the differences between states and the citation levels, and kind of how the surveyors are interpreting citations be kind of standardized across the board. We want to refine and revitalize the reporting process to reduce the annual reports and reduce ancillary reporting. We also would like to see the state come out with specific guidance for specific categories of reporting, such as an abuse and neglect and other things that you can read here. And then we also want to eliminate duplicate reporting from the state rules that are in federal rules. But those rules would then exclude resident-to-resident altercations and injuries of unknown origin when there's no apparent impact to the organization or the resident. And that's something I'm kind of excited to share. We'll be hosting a PAC fundraiser throughout the annual conference. We'll be auctioning off a bunch of fun items. We'll also be hosting a Monday night kind of networking event that'll have a heavy PAC theme, but also you're welcome to come. It will be at the IDC in the Amway Grand Hotel. The IDC is a speakeasy, and I won't reveal the location quite yet, but it is a very unassuming door in the hotel. I'll say that. I'm really thankful again to Betsy Bale for once again stepping up to the plate and donating a fishing trip with her and her husband for 4 people. We break it into 2 groups of 2. Last time we did a raffle and Sue Hurst and Deb Allen won. So you can see their photo here and kind of their fishing haul. I heard it was a really fun time, and I thank them for the creative photography with the sunglasses and the leading age. I couldn't have asked for better advertising, and everyone reported that it was just a blast. So I'm really excited to be offering this again. And I'm looking forward to meeting everyone at this networking event in person again. It'll be a fun time. So we're going to pause for questions. I think I may have a chat or 2 here, so we'll see if that's a question. Oh, nope, just someone welcoming Caitlin in.
Thank you so much.
Thank you, Kevin. Right now, I don't have any other questions. Of course, I'll be hosting the webinar, so I'll be on the call the whole time. So feel free to add them in. Right now, we're going to move forward. I'll be introducing our guest speakers today as they talk about provider relief funds. They are Rob Long and Larry Kearney with Plant Moran. Plant Moran has been a longtime business partner with Leading Age Michigan, and we really appreciate their support. And these 2 gentlemen are some of the best experts in the field of healthcare, and we're very excited to have them today. So with that, I'll be transferring the thing over to Larry so we can get this set up.
Perfect, thanks, Dalton. I'm gonna work through my technology here, get this set up. And I'm just gonna swap this quickly. All right, Dalton, it looks good. All right, perfect. Yeah. Thank you. Apologize for the technology delay there, but thank you for the kind introduction, Dalton. I'm actually going to turn my camera on too, so you can get a video of me. Good morning, everyone. Thank you for having us today. We're excited to talk about. I think I had spoken to the group through these Safe and Calm webinar series about 7 or 8 months ago, when we thought the first reporting portal period was going to open in January of 2021. But here we are 8 months later. The portal is open, and we have, I think, some meaningful updates that we want to communicate with the provider group, and kind of talk through some of those changes and some of the questions that have come up along the way here. So I have a pretty robust slide deck here. I may not be able to touch on everything, but I intend to provide the deck and the opportunity to ask any questions either here on the webinar, or you can contact Rob or myself after as well. So I'll get us moving here. So our lovely pictures of Rob and myself. So we're going to talk about a few things here, including the latest guidance that's been issued by HHS and HRSA, a quick overview of the reporting portal and what that looks like now that it's open. Some top ideas and questions that we've been receiving from clients and others around the reporting of the provider relief funds. And then we've also included some data sources and links to some portal resources that are pretty well laid out on the CMS PRF website. So let's jump in here. So we've kind of started all of these presentations with a disclaimer that the information that we're providing today is as of today. As you've come to know, over the past 15, 16 months, this guidance has changed frequently, with the most recent update being about a little under a month ago, July 15th, on updated FAQs. So we want to provide that disclaimer, and any examples we're giving are interpretations of existing guidance. There's not a lot of prescriptive guidance that HHS or HRSA is providing here. They're really leaving it up to the discretion of the provider on a lot of these items. And then we further would recommend that you consult with your accountant or legal counsel, depending on any specific circumstances for your organization. So what is that latest guidance that's come up? So around mid-June, the most current post-payment notice of reporting requirements came out that describes what needs to be reported in the reporting portal. So that reporting portal opened July 1st for the first reporting period. We'll talk about what that is in a little bit. And then there's been updated, modified, deleted FAQs that have been coming out during the month of July here that have clarified some items, maybe made some things a little less clear that we'll talk about as well. So from that 6/11 post-payment notice, there are really three main items that came out of that we want to touch on. So the first was this concept of a period of availability of funds. If you remember, under previous guidance, the use of funds was under an 18-month period, the calendar year of 2020, and then the first 6 months of 2021. Under the new guidance, it created 4 periods of availability that is now based on the date payment is received. And I'll have this laid out a little bit on another slide so we can kind of see what that means based on the date of payment. The second concept that changed a little bit here was the lost revenue determination. And this one was actually pretty favorable for providers. So right now, the new guidance calculates the lost revenue on a quarterly basis, and each quarter now stands alone. So if there was no lost revenue in a given quarter, that quarter does not count in the lost revenue calculation. And I've also provided an example of that we'll walk through here this morning as well. The third big item here was that this portal reporting now includes the nursing home infection control distributions. Those distributions were specifically excluded under previous guidance, but now they are included, and there's some concepts and considerations that we want to talk through on with those payments now being included. So this payment note, or this reporting notice, now supersedes any previous reporting requirements. The most recent one was in January, but there were about 4 or 5 before that as well. So the current 6/11/2021 post-payment notice is applicable for all past and future PRF distributions. So you may have seen this table. This table came out with the reporting notice and describes the period of availability and the use by date associated with the timing of when a payment was received. So what this is describing is if you received a payment in this first column during this time frame, you have this time frame to use the payment. We'll talk about that. And then the reporting time period is the 90 days subsequent to the end use by date. So this first reporting period that we're currently in right now applies to any payment received during from April 10th to June 30th of 2020. So a little over 2.5 months worth of payment activity. It generally applies to the phase 1 payments or any skilled nursing facility targeted distributions during that time. Those are the general payments that we're experiencing with our client base or providers during that time frame. So the payments received during that time frame can be used or are available for either expenses or lost revenue from the period of January 1st, 2020 to June 30th, 2021. So those funds will either need to be reported as reimbursing eligible coronavirus-related expenses or reimbursing lost revenue due to the coronavirus pandemic. So as you can see, as we move down the table, the payment received periods are in 6-month increments. The period of availability, the begin date always is January 1st, 2020. So no matter the time that you receive the payment, you are able to retro and go back to apply that receipt of funds towards eligible expenses or lost revenue beginning with January 2020. The end use by date gets extended by 6 months as the period of receipt gets extended here. So really the time frame to use the funds varies from either a 12-month to 18-month period as those payments are received. So a little bit of a longer time frame that we saw previously. So on the second item from the payment notice or reporting notice that was important is the new considerations on lost revenue. So I've laid out a pretty basic example and laid it out based on the option 1, which would compare your 2020 actual revenue to the 2019 actual revenue. But this concept would also apply towards option 2, which compares the 2020 actual to the 2020 budget. I just didn't want to crowd up the slide with both options here, but the concept applies to both option 1 and option 2. So under previous guidance, the lost revenue calculation was understood to accumulate changes in revenue over your reporting period, and then that net lost revenue would be available to be applied against provider relief funds. So the previous guidance was a 12-month calendar year 2020 and a 6-month January to June 2021, so 2 reporting periods. Under that guidance, it would have accumulated the 4 net changes in the top row to get to a loss of $800,000. And then the period 2 would accumulate the second section for a net change of an increase of $100,000. Under the new guidance, this is now a standalone quarterly calculation where any increases in revenue are excluded, as I previously mentioned. So how does that change the calculation? First, this is now an 18-month reporting period. So it takes into account the 4 quarters of 2020 and the first 2 quarters of 2021. And if we were to accumulate just the quarters that experienced the loss, that would increase the lost revenue calculation by $200,000. So we'd only be taking into account these losses of 400, 400, 100, $1 million in lost revenue for the first reporting period. So that's a pretty significant change and can have a positive impact on being able to claim lost revenue as a eligible use of funds. So one of the other changes that I mentioned is that there were some FAQs updated. I'm not going to go through these extensively, but one I did want to point out is related to this one at the bottom regarding lost revenues. How should lost revenues be calculated, and how should contractual adjustments from all third-party payers be treated? So this FAQ is kind of confusing for the healthcare providers in that it says it should exclude the amount of contractual adjustments and charity care adjustments. From our discussions and our understanding is that this is not intended to report gross revenue. The intent is still to report net, and that there are going to be a clarifying FAQ that provides the example. So you'll still be reporting net revenue and the change in net revenue from one period to the other, and then this FAQ will be clarified. But that's one that we've heard a lot of questions about how to interpret. Excuse me, I'm fighting a little frog in my throat here. So next thing we want to quickly touch on is the portal and the data elements associated with it. Rob, do you mind stepping in here? I don't want to, when I go on mute for a second, fighting something. I don't want to start coughing in everyone's ear.
Sure, thanks, Larry. So just looking at the data elements here, I don't know. I guess I'd ask the group to make sure that if you haven't spent time in the portal, that you get in there, because we have had some comments about the functionality being a challenge. Like, for example, the ability to register a parent if you have a consolidated group where you want to have a parent sharing funds between subsidiaries. Not everybody's having the same experience. It's not universal. So, you know, I'd say most people are not having trouble with that, but some are. So I'd encourage you to get into the portal as soon as you can, and make sure that you're able to set it up the way you want to. These are the data points, and the one that I wanted to point out, it comes up later in this presentation, is that they're asking for you to compute interest earned on the funds that you've received for the period of time you have them. My expectation is that's probably not a big number. Most people aren't generating much interest in their cash accounts, but that also is not a clear-cut computation like some other things. So that's one thing to point out here. So I'm gonna I'll just speak thanks just off the next slide here. The one thing I wanted to point out is, while the portal is a big deal and we finally have a place to put the information, we still think most of the analysis and the work that you're going to need to do is prior to getting into the portal, because other than a couple of things, it's really just you know, just input sheets. It's not there's not a lot of analysis or intelligence in the portal. So you're going to be doing the work outside of the portal to make sure that you've got an understanding of your expenses and your lost revenue, and that you're capturing that correctly outside, and that's your record. So we're emphasizing that whatever analysis you do is done up front before the portal. So
Thanks, Rob.
Mm-hmm.
So we've included one, I think, relevant example now that the infection control dollars are being included in this reporting portal. So I wanted to quickly walk through that and kind of lay out this period of availability and payment received period, and how that may interplay with future payment received periods, because some of this funding specifically for skilled nursing facilities has been split into two different periods. So as we previously talked about, the general and targeted SNF funds, those are received generally in Q2 of 2020, which is included in this first reporting period. So this reporting period is the funds received can be used during, or the period of availability for those funds is from the Q1 of 2020 through the Q2 of 2021. So those funds are going to be reported on, how we used them, for whether they be for expenses or lost revenue. The other thing we wanted to point out is that the infection control funds were generally received in the second half of 2020, or could go into the first quarter of 2021, depending on if you were eligible for incentive payments. So those are not being reported on now, but will be reported on in future periods. So there's got to be consideration of how those funds are going to be shown as being used for coronavirus-related expenses. So we've laid out pretty much just a way to consider this, and showing that these funds have been used for eligible expenses. So under the payments received, they've received other assistance from Medicaid, which for Michigan facilities could be something related to testing that's directly related to an expense, or other support payments that are intended to be used for expense reimbursement. So they're directly tied to expenses. And then as we step down, the targeted funds and general funds can be used for other COVID expenses, or other COVID expenses that may qualify as infection control related expenses. So under this presentation, we're showing that those COVID expenses that could qualify for infection control are being reported in the portal and applied against targeted funds. So we're using up all those expenses and getting down to a net remaining of 0. So that we've utilized all the funds between eligible expenses or lost revenue. But the consideration here, or the issue with this, is that in a future reporting period, we're going to have to use the infection control funds for eligible expenses as well. So there's a concept that Robert brought up, that we need to look forward towards future reporting periods on how the expenses in a different, that have been received in a different time period, are going to be shown as being used as well. So on this next slide, we lay out a similar concept, but we withhold the expenses that have been identified as infection control eligible and report those in a future period. And as you can see with the facts and circumstances that we've laid out in here, it doesn't change how much needs to be repaid, but it does allow you to consider expenses in a future period when those infection control funds need to be reported.
Larry, can you go back a couple slides? I want to point something out. So,
sure.
So there's 2 points that we're making here. One of them is, while we're only reporting in period 1 funds received at this point, our primary takeaway here is looking ahead to the next reporting period with what we know, to make sure that you're considering what you're going to need. In this case, the example is infection control dollars. You can't offset that with lost revenue. The terms and conditions don't allow that. So you want to make sure you're setting aside enough expenses that you can take credit for that money in the second period. So how you approach your analysis should take into account future periods. So the second thing is just another illustration of the difference between the payment received period, which is when you got your provider relief funds, and the period of availability, which is the period that you're analyzing the use of those funds. It's complicated on how those are different periods of time. So an example of how this might be complicated is with the recently passed Senate Bill 27. So, so to the extent that you have had a drop in occupancy in the first 2 quarters of 2021 related to 2019, so you're submitting for the payment of the $23 a day. That is an additional source of revenue that you need to consider in this analysis, because the period of availability, the period where you're analyzing the use of the original provider relief funds, extends into June 30th, 2021. So that's a recent development. I wanted to just point that out. That's not in the slide deck, but we've been talking about that. So hopefully that makes a little bit of sense in how you think about this first reporting period and how you maybe need to look ahead to what's happening in future reporting periods, and also taking everything into account. So thanks, Larry.
Yep, thank you. So we wanted to touch on a few ideas and questions that have been coming up frequently through our conversations with clients and other associates and internally around the reporting and the guidance and interpretations of that guidance. So we've created this top 10 list. It may not be on your top 10 list, but it's something that we think are relevant to a lot of providers that have received these funds. So I'm going to be monitoring the time here so I don't eat up all the time, because I know Deanna's got some at the back end here. But the first one we've heard a lot is related to this parent subsidiary concept and a controlled group concept. This may come up more on a for-profit group rather than a not-for-profit group, that the leading age members may be more likely to fall under the parent subsidiary reporting. But I think it's probably better shown in this graph here on what currently qualifies as the parent subsidiary under the definitions that are in the frequently asked questions as well as the reporting guidance. So there may be a situation where there's a common owner group that has, I won't call it interest, but oversight of a group of entities that doesn't have a direct ownership link. So under current definitions, this top group would not be under the parent subsidiary considerations. And the bottom it would, because there's a direct ownership linkage between a parent and subsidiary under a parent B or parent A. So there would be the options to report at the parent level and share the general or targeted funds for the skilled nursing facilities under this parent subsidiary situation. Rob, I know this one can get a little complex. Anything else to add on this?
The only thing I would add is that if you don't have a parent subsidiary relationship, or like the below where it's clearly control at the parent level, if you have something broader than that, then that's something you probably need to think about if you want to share funds, because it's that there's some, I think there's some advocacy going on to try to broaden that definition, but it's not right now. So so if you have something more than a parent sub, like joint ventures or something like that, then that's probably something you want to take a look at before you're sharing the money. So.
Okay. The second question, which I think is meaningful for our Michigan providers, because there's been a decent amount of Medicaid funds or funds that are seemingly from the Medicaid pot, and how those are considered, whether they're considered patient service revenue and play into a lost revenue calculation, or whether they're considered other assistance received. So I've included some FAQs in the post-payment notice on how it's laid out there. But again, I think on this graph from left to right on how or what the intent or purpose of those funds that have been received are related to. So on the left, if there's a general or less clear link to coronavirus related expenses, and which may be this $23 per day add-on as a blanket funding source, it may be more likely in the patient service revenue category and included in the lost revenue calculation, versus on the right-hand side, if there's a clear link to COVID-related expenses. I think I brought up previously on the testing reimbursement, and there's a clear link between an expense and the reimbursement from the state of Michigan, then it's likely not included in a lost revenue calculation, or at least that's the way we're interpreting it, for how those additional funds factor into the portal reporting. So next one, we've gotten a lot, and this one has nothing definitive on here, or what we've seen from guidance on the use of lost revenue option 2 and the budget that is being used, particularly for the first and second quarter of 2021. So the FAQs and post-payment notice indicate that the budget needed to be completed and approved prior to March 27, 2020, just around when the pandemic began, but that for calendar year at a minimum, providers likely didn't include the first half of 2021 in that budget process. So there's questions out here related to this. The interpretation, or maybe the common sense way to use this, is if there was a budget in place, that 2020 budget would be used for calendar year 2020, and then possibly the first half of 21, we'd replicate the first half of the 2020 budget again as the base period. So that's kind of, I hate to say common sense way to think about it, but it seems like that may be the intent of it. And there's been a webinar put out by HRSA that may lead towards that conclusion, but it's not explicitly written in guidance right now. So that's something that's out there that we're getting a lot of questions on, is how do we apply this budget concept to a period that our budget clearly wasn't issued prior to that March 27th, 2020 date. The fourth one is around the lost revenue calculation and method 3, which is described as any reasonable method to determine lost revenue calculation. So the risk considerations here is that it needs to have a reasonable approach, adequate documentation, and really relate towards this, relate to the coronavirus pandemic. And the risk here, HRSA and CMS have already shown that there's risk around it, saying that if you choose this option 3, there is a higher likelihood of audit, review, and that this one is likely going to be circled pretty quickly if this option is chosen to review if the method seems reasonable. Also within the payment notice, it indicates if they deem that it is not reasonable, will allow you the option to choose option 1 or option 2 and resubmit. It doesn't seem, from what we can tell, there's any type of adjudication process to figure out whether or not method 3 is actually reasonable. It just towards an option 1 or option 2, and you can resubmit within 30 days. So there's a little bit of risk around there. So this may be another option to really review each of the scenarios to see what may be either more beneficial or less risky around an audit process. Keep an eye on time. Yeah. Touch on this quickly on when an expenditure is considered an expenditure for PRF. It really boils down to, is it to prevent, prepare for, or respond to the coronavirus, and is it reimbursed by another source? A lot of the webinars that HRSA has put out, documentation is really, can we tie it to the coronavirus pandemic? Is there adequate documentation to substantiate that? And is it being reimbursed by some other method? if it checks those boxes or doesn't check it in the matter of being reimbursed, then I think we could consider it an expenditure for PRF. But HRSA is not prescribing anything that is definitive expense. There's been some direct questions around, is this a coronavirus related expense? And a lot of the responses they give are, the burden of proof is on the provider that adequate documentation is maintained to explain that it's for the coronavirus pandemic. They're really leaving it up to the provider's discretion and supporting it with adequate documentation. This one may also apply to this group around a continuum of care, CCRC, on if assisted living or independent living is considered in the patient care revenue categories. In the post-payment notice, it gives a definition here that specifically says that assisted living facility related rental revenue is included, can be included. And there's also an FAQ around entrance fee amortization, which would lead you to believe independent living may be included as well. It doesn't explicitly say it as it does assisted living, but it may come back to that reasonable assumption or reasonable method to determine the lost revenue, and that it's consistently applied from period to period. This one Rob had touched on previously, briefly, so I'll just touch on it quickly here on the interest earned. I think this really comes back to another reasonable method determination by the providers on the interest earned on provider relief funds if they maintained in an interest-bearing account. So when is that? One of those funds used may come into the calculation of when does that lost revenue come into play, or when those expenses incurred that are provider relief fund related. But it's likely a reasonable method support here, and the funding or the funds related to this are likely not significant. So it's something that if you can support it with a reasonable method, it's likely going to be okay. I think I've touched on this one, but yes, maintaining documentation is going to be very important related to this, and the FAQs specifically say it needs to be maintained for 3 years after the date of submission. So there would need to be supporting documentation for identifying expenses related to the pandemic, as well as the lost revenue determination. Specifically calls out there's not a lot of documentation that needs to be submitted at this first reporting portal time. Really, there's only a few things called out. One being a copy of the budget, if that option 2 is being used, as well as an attestation. Or if option 3 is being used, the narrative and calculation on the lost revenue. So not a lot needs to be submitted at this time. Excuse me. These are just a few things we've kind of touched on this, but what are some things you've heard about the portal process? One is that there's only one access point or one access person that can get in. So if you're using multiple people to gather the data, only one person can input that at a time. And then it's a linear process. So you'll have to go for a tab. It's not set up in a tab, but you have to start at sheet 1 and work your way through sheet 12 to get the information in there. So organizing your information ahead of time is very important. And then lastly, on our top 10 here, what are the different periods funds may be reported? This, depending on your year end, will impact when it's reported on your financial statements or in the portal or any potential single audit or CFA reporting. So if you are a 6/30 year end, you're going to be the first ones up on reporting on the CFA, and that portal 1 or period 1 reporting will be on your 6/30/21 year end CFA. So we've kind of laid out the table here, and like I said, I'll provide these slides so you can look at it, and it's laid out in the guidance as well. But there's various reporting periods that the funds could be reported. So I'm going to move quickly through those, and I've also, like I said, we included some resources here. There's a lot of good data on the sites, including webinars and slides that HRSA's put out. So I'd really suggest you get acquainted and get comfortable with the guidance out there. If there are any questions, I guess Deanna mentioned we could take some now if there are any questions now, but I've also included our contact information as well if you have any questions after the fact that you'd like to discuss with either Rob or myself.
Excellent. So while we give everyone a moment to type in their questions, I'm going to go ahead and transition the slides back to our normal presentation. Thank you for presenting today, Larry.
Yeah, thank you, Dalton.
And Rob, of course.
Thank you.
Okay. So I'm going to open up the questions now, see if we have any. And as I said, you're welcome to reach out to them at the contact information. The first question is, will the slides be available? Yeah, we'll have them in PDF after the webinar, I believe.
That's correct. Yep.
Distribute those out. I have some other questions, but they seem like they're for Deanna right now. So thank you, Larry and Rob, for presenting today. And thanks for getting on at 10 o'clock on not a regularly scheduled call for your schedule. So thanks for taking the time today.
Thanks a lot.
Thank you for having us.
All right. And with that, I'm going to throw it back to Deanna for our regularly scheduled program.
Okay, well, thank you. Thank you, Rob and Larry. We are running a little bit behind time. I want to let you know that I do have a lot of data slides here, but I'm only going to go through a couple of them this morning because of time. And I basically just want to say that cases are going up just slightly in our residential care facilities, almost so slightly that it's still, I mean, we can see a small bump in the slides, as you'll see as you look at the slides later, perhaps, but the numbers are still pretty small. But there are a couple slides I want to call out to you, and this first one I think is important. This is a CDC slide of the situation update everywhere. And this slide identifies uses two basic indicators. And the criteria for that indicator are on the left part of the slide. So the second number is the PCR test positivity rate in a county, and the first number is the total new cases per 100,000 persons in the past 7 days. And they use both those indicators, but as they use those indicators, they use the highest indicator that's going to identify that ultimate color code. So remember that routine testing has decreased considerably. So the percentage of PCR tests that are positive is always about who's getting tested. And if those persons are mostly with symptoms, obviously your rates are going to go up. And it is a rate. It isn't based on how many tests are actually delivered. So this map could be a tad misleading, but I don't want to move away from the idea that there is obviously increasing transmission across the states. Quickly go to the next slide, please, Dalton. So this is the slide that shows us where we were a few weeks ago. We were mostly blue, you can see. And this is just community transmission level. So we are seeing an increased amount of transmission in these slides. And then go to the last slide in the data pieces. It's that very multiple colored slide toward the end. You can just keep going. There's quite a few slides here, Dalton. And these are our normal slides. You can look at these at your leisure. You can see that we have higher transmission rates. Keep going, Dalton, that's not it. Here, this is the slide. So this is the slide that we first introduced 2 weeks ago. It's the CDC slide. You can see on the left, those were the cases reported per 100,000 population. And this slide compares each county to its own vaccination rate. And we talked about this a bit last time, as I said before. Note that, you know, the map is much more red on the right. This was as of, I took this off the CDC website yesterday. And the purple areas are the ones that are a little bit concerning to me because those are counties with high vaccination rates and high transmission rates. The lower counties, you'll notice, kind of predominate in the southeast portion of the US and a little bit to the west. The reddish, orangey red and reddish areas, those are lower vaccinated counties and high transmission rates. So as we look at this and try and figure out, you know, what the risk is to our vaccinated persons, this is something that we'll track. But obviously, there is more transmission going on in most of the US, not so much in Michigan, but it is increasing in Michigan as well. So at this point, we're going to go to the general resource and guidance. As I said before, there isn't really new specific rules that everybody has to pay attention to, but we do have a few things we want to talk about. So the first graphic is, the first slide, excuse me, is on the Delta variant. And I don't want to dwell on the Delta variant a whole lot. I'm sure we've all heard all about it. But there's some new information that's come out in the past few weeks, and I want to make sure that we have communicated the most up-to-date information about that. We know it's more contagious. Last report is that it's still more than twice as contagious as other variants. It might, although it's not 100% clear yet, cause more severe illness. The CDC reported that 2 studies have shown an increased hospitalization rate with the Delta variant. At our last webinar, we reported that transmission of the virus in vaccinated persons isn't really happening much. But we have more information about that now. They have identified that fully vaccinated persons with symptoms who have infectious COVID infection, they are contagious. But they're not really sure about those who are asymptomatic. So the CDC is continuing to look at that. So you must consider anyone who's vaccinated, symptomatic and positive as very contagious, just like anyone else. The CDC also thinks that the transmission period may be shorter, though, for a vaccinated person. And of course, this CDC article that's linked here notes that vaccines are still highly effective against the Delta variant. There's been a lot of discussion about whether boosters will be needed. This Kaiser report linked here announces that West Virginia is going to be looking at antibody levels in nursing home residents who are vaccinated to see how long and how well their immunity is holding. And they hope to inform the regulators and policymakers, if you would, about whether or not boosters may be needed and at what point. So as they report, we will be monitoring that as well. There is another new CDC study out, and this one emphasizes the need for vaccinations even for persons who have been infected with the virus. They've identified through some of their studies that the vaccine offers greater protection over time for persons who already have some immunity from the infection, and they're strongly encouraging those persons to become vaccinated as well. We sent this out in our member update several days ago, but we want to note that the CDC has again extended its eviction moratorium, but only for those counties with substantial or high levels of community transmission, which in most states really is an awful lot of counties. Although we expect that there will be some legal challenges to the CDC ability to do this because there has been some Supreme Court decisions related to it. The idea was for the administration to give time to provide better rent relief through government programs to renters. The notice identifies all the persons covered under the rule, and that same attestation as to financial need and use of all government assistance currently available is still a requirement. A brief note, if you're interested, the CDC has also issued a report on disparities among vaccinations in staff and long-term care facilities. They do find that physicians and therapists are most likely to be vaccinated, while nurses and nurse aides tend to be at the lower end of vaccination proportions. They believe that these factors, these characteristics display equity issues, since nurses and nurse aides tend to be mostly women and largely persons of color. And so they are looking at some of the things that might assist in helping those groups become vaccinated. So we've heard that there's some confusion about the two primary QSO documents that provide pretty much the bulk of rules for Michigan facilities. We want to remind everyone this morning that the QSO 2038, that is the testing requirement QSO. That is for nursing homes only. MDHHS does not rely on those rules for any other setting other than nursing homes. It's still very pertinent, that difference, because nursing homes do have to test twice weekly if they are in any county with a CMS transmission rate of more than 10%, or if they're in that red category. But it only applies to nursing homes. It is only 39, QSO 2039, that applies to all residential settings in Michigan. And that sets the minimum expectation for routine testing at weekly for all of those other areas. The CDC has announced that there will be changes in the NHSN COVID vaccination data for healthcare personnel. The link to the update is on the slide. There are 4 basic changes that they're anticipating. I'm not going to go through those today. You can read. They are anticipated for the fall, so they're not in place yet. Move to the next slide, though, please, Dalton. However, there was a notice that went out to NHSN users, 2 facilities, in the last week or so. The CDC wants to ensure that the vaccine information is being reported accurately, especially for staff, and that facilities who might be having problems with accessing vaccine are documenting that accurately in their data submission. They also provide a reminder that if there are problems, you must be working with your state and local authorities about that. On July 29th, the department updated its guidance to protect residents of long-term care facilities. And I have the link to that guidance on this slide. If you remember, this came out several months ago, and this is the guidance that included independent living in certain quarantine and testing protocols, even though there's no requirement in Michigan to test either in independent living or unlicensed assisted living. So at that time, we contacted MDHS and let them know that we thought that this was a very difficult time, a difficult document for independent living. It was really inappropriate for them. And that independent living doesn't even often know who's vaccinated and who's not. And they responded that this was a best practice document only. It was not a requirement for anyone. So that's what we consider also to this update. Some of these recommendations are not appropriate, either for unlicensed assisted living or independent living. Otherwise, though, the testing and quarantine guidance here, though, is pretty much in alignment with CMS and CDC for other residential settings. So they did update this on July 29th. Move to the next slide. So when I looked at this first, I didn't see a change except perhaps in resource links. These are the differences in the quarantine requirements. The new one is above. There really are no difference here, and this is pretty much in alignment with what you have to quarantine according to the QSO and the CDC link from it. The change was in testing recommendations for persons who were vaccinated. So what this document actually did was simply update these recommendations to match the current May 5th department testing guidance. It doesn't really create a change in the rules. And at this point, what I do is I'm relying on what is said in the epidemic orders. Those are the things that really apply the actual rules. MDHHS has kind of backed off from the idea that these supplementary documents are really requirements. So before we end for the day, I have a few final updates. The Small Business Association has launched its portal. This is to help speed up decisions about whether or not your Paycheck Protection Program loans will be forgiven. Members can either work with their lenders or they can use information from the portal for those who have loans of $150,000 or less. The link for the information and the portal are on the slide. The Agency for Healthcare Research and Quality yesterday issued a best practices document for administering vaccinations in nursing homes. Apparently there's been some consideration for seniors with a lot of muscle wasting to make sure that there's no nerve damage, etc., to make sure that you're really administering the vaccinations as best for some seniors and their body types. And of course, the links are on the slide. This last weekend, the Washington Post reported that the White House is considering mandating vaccines for all nursing home staff. And they're trying to figure out a way to do that. There are no details about this at this point, but they seem to be looking at ways to strongly encourage mandatory vaccines at the facility level as well, and perhaps doing that by restricting Medicare dollars or other federal funds. So if they're not going to mandate across the board, but put pressures on facilities to mandate, that could be really challenging because unless there's some federal law that requires it, these pressures could make it very hard for nursing homes financially. If these funding restrictions were put into place, we know that there are a lot of issues with unions right now and whether or not they're going to allow mandatory vaccines. So Leading Age is looking very seriously into this, and when we know more information, we'll certainly let you know. And lastly for today, I just wanted to remind everyone that OSHA, and in Michigan, that would be my OSHA, continue to monitor healthcare facilities for compliance with their the emergency temporary standards. We wanted to just let you know that 2 healthcare facilities, but they were not nursing homes, but they were both fined a significant amount of money in another state for not allowing the masking rules, for not following the masking rules for care of persons with COVID, not providing or conducting the medical evaluation prior to using N95 masks, and of course, not doing appropriate fit testing. We know that in the past, it's been kind of loose about this. Surveyors were not looking hard at it, but my OSHA will be. especially since they have taken on the temporary emergency standards as well. So we just wanted to give everyone a heads up. Okay, so not a whole lot of new rules, but as usual, the issues continue. So Dalton, let's see what questions there are.
All right, thank you, Deanna. We have a couple of questions right now. The first one, we are located within a hospital setting where they are initiating a no visitor policy beginning Monday. Are there any changes with the visitor restrictions, and do we follow the hospital facility restrictions versus what the recommended restrictions are?
I think that it depends on, I would be contacting the local health department. Just on the basis of the CMS rules, you would have to allow visitation. But remember that state and local authorities have the ability to supersede those regulations when there is increased security, safety risks. So I would definitely be contacting the local health department and seeing what they say about visitation, and I would probably follow their guidance.
All right, next question. We are currently in outbreak testing due to a positive employee. With the first round of testing, a resident has tested positive in another area. Visitation is canceled. Communal dining and group activities are also canceled. Do all other residents on that unit where the positive resident is needed to remain isolated in their rooms? Do residents in other areas need to remain on their respective units?
Yes. If you're in outbreak mode and you have, it sounds like you have more than one affected area, you have to lock down both those affected areas and confine them to their rooms. Visitation can continue for compassionate care, depending on where your affected areas are. I'm not sure about visitation in your unaffected areas. If you're having other outbreaks in other parts of the areas, it would depend on how your situation is, and I would look at that individually based on where your infections have occurred. I'm not sure if I answered your question. Let me know if I didn't, or you can shoot me an email.
Right, this next one is a statement, not a question. If vaccines are mandated in nursing homes, the staffing crisis that is already occurring in nursing homes will only get worse. Nursing home staffing concerns are already a huge challenge. Mandation will only make it a staffing challenge that may make continuation of that nursing home impossible.
And we are fully aware of that. That's why this report from the Washington Post concerned us greatly. We put out our own statement a couple of weeks ago about the fact that we think that every facility has to make their decisions about mandatory vaccines based on their own situation, and we're fully aware of the staffing crisis, which is one of the reasons why we're talking to Leading Age about this piece, and I know that they're monitoring it closely.
All right, thank you. We have another question. We have many of our team fit tested, but not all. The purpose is to have a large group ready to serve in isolation, which is the only time our policy requires N95 masks. Do you believe the intent is to have an entire facility fit tested, or just those that would serve in the isolation area?
If you're not serving a COVID positive person, you do not have to wear an N95 mask unless they're in quarantine. Quarantine will require that as well for serious exposures. But no, it is not expected that you do that throughout your own facility. It is expected that you do it for direct COVID care and persons under quarantine.
All right, that was our last question for the day.
Okay, well, thank you, everyone. We will be convening again in 2 weeks, and we appreciate your help throughout this entire period of the pandemic. We know that everyone has and is continued to be burdened. And if there are ways that we can help, we want to make sure that you have the education and resources necessary. So please continue to send emails to either Safe and Calm or to my email address or Dalton's email address, and we will continue to try and support you the best we can. Have a good day.
Thank you, everyone.
Thank you.